Good evening, everyone. My name is Colin Lynch from the Sunnybrook Board of Directors, and tonight I'm pleased to offer the introductions for a discussion on the importance of sleep. Before we get into tonight's topic, I'd first like to acknowledge that today is an important day, and we acknowledge the reign of the late Queen Elizabeth II and acknowledge her service to our country and to the world. This is the first discussion since our summer break, and we look forward to continuing to provide great monthly lectures virtually and back in person at Sunnybrook when it is practical and comfortable for everyone to attend. I invite you to join our mailing list to receive notification about upcoming lectures. You can also find session information on the Speaker Series website where you have access to this evening's talk. Sleep health is something that affects us all, and our panel of experts is here to offer some important insight, guidance, and suggestions. Tonight's presenters will be speaking about how sleeping well and maintaining your body rhythms is critical for brain health, and exploring the links between stroke, sleep, and restless leg syndrome. And they'll also be talking and taking a look at obstructive sleep apnea and your health, an overview beyond snoring. We hope that the information presented resonates with you and helps you navigate your personal health management. To get things started, I'd like to now introduce tonight's moderator, Dr. Brian Murray. Dr. Murray is the head of the Division of Neurology at Sunnybrook, an associate professor in the University of Toronto's Department of Medicine, chair of the Royal College of Physicians of Canada Specialty Committee in Neurology, and chair of the Research Ethics Board at Sunnybrook. He is also an affiliate scientist in evaluative clinical sciences with the Hurvitz's Brain Science Research Program at the Sunnybrook Research Institute. His clinical focus is on the neurology of sleep, with research interests in the relationship between sleep and behavior. We are very fortunate to have Dr. Murray guiding us through tonight's session. Thank you all for being here, and I'll now pass the microphone over to Dr. Murray.
Thank you very much, Mr. Lynch. Good evening to you all, and thank you for joining us remotely this evening for our speaker series. I'm the head of neurology at Sunnybrook and very proud that Sunnybrook has been recognized as one of the top neurology hospitals in the world. We have expertise in many aspects of brain health and distinct expertise in neurological aspects of sleep. Tonight, our series is called A Good Night's Sleep, and we are very lucky to have a great lineup of Sunnybrook experts speaking with you about the importance of sleep. I'm very happy to share with you some of the work our group has been doing. Dr. Andrew Lim will begin our session with his presentation, Healthy Sleep, Healthy Clock, Healthy Brain, How Sleeping Well and Maintaining Your Body Rhythms is Critical for Brain Health, taking a look at sleep and cognition with a focus on circadian rhythms, time of day rhythms. Dr. Mark Boulos will then share a presentation exploring links between stroke, sleep, and restless leg syndrome. And next, Dr. Anu Tandon will present obstructive sleep apnea in your health, an overview beyond snoring, looking at sleep and your health. After our presentations, we'll have time for you to ask our panel of speakers some questions about sleep and how it relates to your health. Thank you to everyone who has submitted a question online. We invite you to send your questions to us during the presentation using this webpage. We may not be able to get to every question, but we'll do our best to answer you in the time we have available. So to begin the series, I'd like to introduce our first speaker. Dr. Andrew Lim is a staff neurologist in Sunnybrook's Department of Medicine, an associate professor in the University of Toronto's Department of Medicine, and a scientist in evaluative clinical sciences with the Hurvitz's Brain Sciences Research Program in the Sunnybrook Research Institute. We're glad he's here to speak with you about sleep and brain health. I'll pass the microphone over to you, Dr. Lim.
Thanks so much, Brian, for the kind introduction. So to kick us off today, I'm actually going to start with a sort of lightly fictionalized case from my own clinic. So this is one Thursday afternoon in 2022 in the Sunnybrook Sleep and Brain Health Clinic. And I see a woman named Beatrice. So Beatrice is a 76-year-old woman who comes to me with 5 years of difficulty staying asleep at night, accompanied by excessive daytime sleepiness, and 1 year of increasing memory difficulty. So it turns out that Beatrice gets very tired during the day, especially after dinner. Some days she will go to bed as early as 7 or 8 o'clock at night, but many days she'll force herself to stay awake until 11 p.m. to keep her husband company watching the 10 o'clock news. She falls asleep very quickly, no matter when she goes to bed. But she wakes up more frequently than she would, like 4 to 5 times a night, and will wake up at 4 a.m. most mornings, unable to get back to sleep. And that's when she begins her day. She's also noticed a bit of snoring as of late, or at least her husband has. Now, over the last year, she's had increasing memory difficulties. So, for example, forgetting where she placed her keys, forgetting what she had gone into a store to buy, for instance. So Beatrice had a few questions for me. The first question is she tells me, a lot of my friends also have trouble with sleep. Is there actually anything wrong with my sleep, or is this just part of getting older? She also asked me, what is causing my sleep difficulties and what can we do to figure it out? She asked me about her memory difficulties. She's worried about her memory difficulties and wonders whether these might be related to her sleep. And of course, she asked, what can she do to improve her sleep? And if improving her sleep might improve her memory and help prevent dementia. So these are all really, relevant and important questions, relevant to a lot of us. So let's go through these questions one by one. So she asked me, whether her sleep is just part of normal aging, or whether there's really something that's amiss here. And I get this question a lot, is my sleep really abnormal? And I have a couple of kind of rules of thumb about that. So really, you probably have healthy sleep if you fall asleep easily and stay asleep anywhere between 6 and 9 hours with no more than a couple of awakenings a night. And you have no trouble at all staying awake during the day, even during sedentary situations like watching television, in meetings, as a passenger in a long car ride, or after meals. So if all of these things are true, which they really aren't for Beatrice, then your sleep is probably normal. So it appears as though, Beatrice is sleepier than she would like to be. She has trouble staying awake after meals, trouble staying awake in the evenings, and also has trouble staying asleep at night. So there probably is something wrong here. So then the next question is, what's causing Beatrice's sleep difficulties, and what can we do to figure that out? So there are a few things that might be going on here. So one thought is, does she have a problem with her body clock, her circadian rhythm? So she has a little bit of evening sleepiness and early morning awakening. When we see those things in combination, that might indicate an especially early body clock. And I'll talk about that in a moment. Beatrice's husband mentions that she snores, so that certainly raises the question of sleep apnea. And Dr. Tandon is going to talk about that quite a bit later on. And Beatrice is on the older end of things and maybe having a bit of memory difficulty. And certainly we know that both age and neurodegeneration can cause damage to sleep regulatory areas that can cause sleep difficulty as well. So let's talk a little bit about circadian rhythms for a moment. So what are circadian rhythms? So circadian rhythms are 24-hour cycles of body functions and processes. And the real function of circadian rhythms is to align body functions to the day-night cycle so that certain things happen during the day, certain things happen at night. And this influences a whole host of body functions, including kidney function, heart function, lung function, brain function, and certainly the sleep-wake cycle as well. How do these circadian rhythms work? So there's a master circadian clock in a brain center called the suprachiasmatic nucleus. That's right here on this MRI scan. Now, the master clock receives signals from the eye, from the retina, which allow the master circadian clock, this is the suprachiasmatic nucleus, to be aligned to the day-night cycle. Then this master clock sends signals to synchronize circadian rhythms in other parts of the body. So in the heart, in the kidney, in the lungs, in the gut, and other places, and especially to regulate sleep. So circadian rhythms have a huge influence on when we're able to fall asleep and stay asleep. So during the day, this master circadian clock, the suprachiasmatic nucleus, sends signals that help us keep awake. So you can see here the wake signals are not there at night, and then in the morning you get these potent signals that keep you awake during the day, and then at night the master clock sends signals to help us to fall asleep. So you can see here in the blue line here, the sleep signals. And so long as the circadian rhythm of the master clock is aligned to the day-night cycle, this works to our advantage. What happens in advanced sleep phase syndrome, which is possibly what Beatrice might have, is that the master clock sends wake signals far too early. So rather than sending wake signals at dawn, the master clock starts to send wake promoting signals in the middle of the night and causes you to wake up really early in the morning, far earlier than you would like to. At the same time, the master clock sends these sleep signals also too early, sometimes even before dawn or before dusk, causing us to be a lot sleepier than we would like to be in the later portion of the evening. Why does advanced sleep phase happen? This can happen for a whole host of reasons. Some of them are environmental. So getting excessive light in the morning can cause the circadian rhythm to advance. Getting too little light at night can cause this as well. We know that genetic factors play a big role. So people who are morning larks tend to have parents and siblings, for instance, who are morning larks as well. And age plays an important role as well. So as we get older, the circadian rhythms will tend to advance a little bit, even in the absence of any other medical disorders. So what about sleep apnea? I'm not going to talk too much about sleep apnea because I know Dr. Tandon is going to speak much more about this later on. Just very briefly, obstructive sleep apnea in particular is a disorder that's characterized by repeated collapse of the upper airway in sleep, not during wakefulness, that results in a restriction of breathing. And this can lead to frequent nocturnal awakenings and low oxygen levels at night as well, and daytime sleepiness. It's extraordinarily common, especially with aging. So although it's relatively uncommon, for instance, in women who are relatively younger, once you get over the age of 65, and especially once you get into the 70s and 80s, a sizable minority of women and even more men have sleep apnea. So very, very common disorder. What about the possibility that some of Beatrice's sleep difficulties may be related to dysfunction in brain sleep regulatory areas? This is certainly possible. So we know now that just like there are brain areas that are devoted to thinking, to memory, to vision, to every other neurological function, there are brain areas that are devoted to sleep and wakefulness. And there are a whole host of brain regions, in fact, that are necessary to keep you awake. And there are a couple of brain regions that are sort of like the off switch of the brain. They're in the hypothalamus, and what they do is they turn off the rest of the wake promoting areas and allow you to fall asleep. And what we know from work actually done in our group is that as you get older, this is a picture of the neurons in this area. As you get older, you get fewer and fewer neurons in this area. And especially slow if you have Alzheimer's disease. So individuals with Alzheimer's disease have particularly low number of neurons in this area. And that the fewer neurons you have, so going leftward on this x-axis, the worse the level of sleep fragmentation. So the more commonly you wake up at night. So it is certainly possible that some of Beatrice's sleep difficulties are independent of sleep apnea or circadian rhythms, but might actually be related to dysfunction in areas of the brain related to sleep. So how are we going to go about making a diagnosis here? So the certain standard, like the standard of clinical care right now is to have a study in the sleep lab. So we bring patients into the lab, hook them up with wires to their head to measure brain waves, to their heart and bands across their chest to measure cardiac and pulmonary function, and wires on their arms and legs to measure movement. And we get information about how well they sleep. The challenge with polysomnography is that it's a visit to the sleep lab. It's pretty uncomfortable for many folks. It's relatively expensive. It requires a specialized technician and a specialized physician. And there are a lot of things that you don't get out of that. So for all this effort, you still can't get great measures of circadian rhythms from a standard overnight polysomnogram. The good news is that we're doing a ton of work, even here at Sunnybrook, in pushing the envelope on wearables for measuring sleep. So we have a number of studies, for instance, underway using soft cloth wearable headbands, using Band-Aid-like devices that you might put on your chest or your finger, or using wristwatch-like devices. And we're developing AI-based machine learning algorithms to use these comfortable and easy to use tools to get useful information about sleep, to measure sleep stages, to detect sleep apnea, and to look for abnormalities that might predict neurological disease. So I think pretty soon there'll be a bright new future for wearable devices that will supplant the uncomfortable sleep lab for a lot of diagnostic purposes. Even so, there will still be unusual cases where these wearables will not suffice. And the great news is coming soon to Sunnybrook is the Gary Hurwitz Brain Sciences Center Circadian Rhythm Lab. So as part of the new Brain Sciences building, we'll have 3 sound and light-proof rooms that will allow us to study in great detail people's circadian rhythms. And they're built to be comfortable for relatively long stays and are sealed off from outside light and sound to allow us to make very careful measurements of circadian rhythms without the influences of external light and sound and other environmental influences. This will be a first in Ontario, so we're really excited that this is coming our way soon. And what about Beatrice's second question? She's worried about memory difficulties. She's wondering whether these sleep problems might be related to, or her memory difficulties might be related to difficulties with sleep. And what we know now from a lot of epidemiological studies is there's certainly a link, an epidemiological link between having certain sleep abnormalities like sleep apnea or insomnia and a future risk of having dementia. So for instance, having insomnia is associated with a 1.5 times risk of having dementia. Sleep apnea, a similar thing, or having very short sleep time. So adults who sleep less than 5 hours a night have an elevated risk of dementia. We've done some of this work here at Sunnybrook. So for example, this is a study of 700 something older adults. And what we did was we had them wear, these are adults without dementia, we had them wear wristwatches to measure the quality of their sleep. And then we asked the question over a period of 6 years, who was likely to develop dementia. You can see the folks here in the dark line with higher levels of sleep fragmentation who woke up a lot at night were much more likely to develop dementia over a 6-year time span than individuals who had relatively consolidated sleep at night. Subsequent to this, our group at Sunnybrook has done a bunch of work trying to understand, what are the mechanisms that underlie this. And over a series of studies over the last 10 years or so, we've shown that individuals with poorer sleep have a higher burden of Alzheimer's type pathology in their brain, so neurofibrillary tangles and amyloid plaques. They also have a higher burden of Parkinson's type pathology, these Lewy bodies that cause Parkinson's disease. We've shown that individuals with more fragmented sleep have damage to the blood vessels of their brain and have shrunken frontal lobes, for instance, in their brains. And more recently, members of my group have shown that individuals with fragmented sleep have brain inflammation, so abnormal function of the brain's immune cells and damage to the brain support cells, these so-called astrocytes. So it's increasingly clear that bad sleep can potentially impact a whole host of brain functions that then potentially lead to dementia. We're very excited to be undertaking a whole host of new studies here at Sunnybrook. We've just started off. This is part of our involvement with the Canadian Consortium on Neurodegeneration and Aging, a study that's taking a look at individuals with mild cognitive impairment. We're trying to identify new wearables-based signals that might predict whether somebody might develop dementia or not over a 1-year time span. So Beatrice's final question is, what can she do to improve her sleep? And even if she improves her sleep, will this help her memory and prevent dementia? So the first thing, and I get asked this question a lot, what are some simple things that we can do to establish healthy sleep? So some of them are at night to establish a relaxing pre-sleep routine, to keep a quiet and dark sleep environment, to not use the bed for anything other than sleep and sex. So no electronic devices, no TV, no work, and to avoid eating in the middle of the night. It's important during the daytime, too, to get regular moderate exercise, to get adequate outside time, and to avoid excessive napping. And above all, regularity is key. You've got to keep the same bedtime, same wake time, and same meal times every day. But what about situations where that doesn't suffice? So for circadian rhythm disorders, like what we think Beatrice might have, light therapy or phototherapy is a great non-drug way of managing these. In particular, for Beatrice's condition of advanced sleep phase, what we'll do is have patients expose themselves to bright light at night in the evening, which will tend to push the master clock later and better align it with the day-night cycle. So by shining light at night, you realign the day-night cycle, so you start to get the sleep signals when you're supposed to at night and the wake signals when you're supposed to during the day. The question is, this is going to help memory. We actually have a study underway very soon here at Sunnybrook that's going to take a look at that. This is, again, as part of the Canadian Consortium on Neurodegeneration and Aging. And we'll be taking a look at folks with mild cognitive impairment, some of whom will have insomnia or circadian rhythm disorders, and then giving them a course of phototherapy and web-based cognitive behavioral therapy for insomnia, in addition to a whole host of other lifestyle modifications, including diet and exercise and cognitive training, and asking the question whether this will improve their memory over a 12-month time span. So we're very excited at Sunnybrook to be part of this study. I won't actually say too much about sleep apnea because I know Dr. Tandon will speak about this, except to highlight actually a couple studies that Dr. Boulos is doing. Maybe he'll talk about these as well. He did a really lovely study really recently showing that in folks who have mild cognitive impairment and sleep apnea, those who use CPAP did a lot better from a cognitive perspective. And I don't know if Mark could be talking about this, but he has a really exciting study of taking a look at mouth and throat exercises as a non-CPAP way of treating sleep apnea. So where do I see the future going? So I started off with Beatrice visiting my clinic in 2020, but what would happen if Beatrice saw us in 2032 instead of 2022? So now let's fast forward to 2032. So we see, a new Beatrice. She's now 71. She's still cognitively well. And instead of seeing us, she sees her family doctor for sleep difficulties. Her family doctor gives her a soft cloth headband to wear at night, maybe some stickers to put on her chest and finger, along with a wristwatch to wear for a couple of weeks. These are analyzed automatically using Sunnybrook developed machine learning algorithms. And these suggest that, number one, Beatrice has advanced sleep phase syndrome and sleep apnea. And two, Beatrice has changes in her sleep brain electrical activity that suggests that she has a higher than average risk of developing dementia in the future. So knowing this, her family doctor prescribes a Sunnybrook developed phototherapy regimen for circadian rhythm disorder and a Sunnybrook developed oropharyngeal exercises for her sleep apnea. So it turns out the oropharyngeal exercises are successful. So the sleep apnea is gone, but the phototherapy is only partially so. But Beatrice has the good luck of being referred to the Gary Hurwitz Sunnybrook Circadian Research Laboratory, or Circadian Rhythm Laboratory, for assessment and fine-tuning of her circadian rhythms, after which her sleep is much improved. She lives for many more years as cognitively sharp as always. That's it.
Thank you very much, Dr. Lim. I'd like to now introduce our next presenter, Dr. Mark Boulos. Dr. Boulos is a staff neurologist at Sunnybrook Health Sciences Center of Research in Sleep Neurology and an associate professor in the University of Toronto's Division of Neurology. Dr. Boulos is here to talk about sleep and stroke with a focus on restless leg syndrome. Over to you, Dr. Boulos. My friend, you're on mute.
How many years do we have to be in a pandemic to learn how to unmute ourselves, right? I was just to say, thank you very much, Dr. Murray. And thank you, Dr. Lim, for highlighting our work together. It's a real pleasure to be here. So I'm a neurologist who is interested in sleep neurology as well as stroke neurology. So it's been really, really a lot of fun over the last many years at Sunnybrook to highlight and to actually examine the links between sleep and stroke disorders. And so let's just jump right in. I'm going to talk a little bit about restless legs for the first few minutes, then talk about potential links between restless leg syndrome with stroke and heart disease. Then afterwards, talk about links with other sleep disorders and stroke. I've actually shied away from sleep apnea because I know my colleague, Dr. Tandon, will be discussing that. So let's talk about restless leg syndrome. And this is actually a really disabling condition. I know this looks like a little bit of a funny cartoon, but in fact, patients are really, really, really disabled when they have this, especially when it's extreme. Restless leg syndrome occurs in about 5 to 10% of the general population, and it's characterized by an urge to move the legs. It begins when people are at rest or they're inactive, kind of lying in bed, trying to fall asleep. It's relieved with movement, and it gets worse in the evening or nighttime, and it's not better explained by another condition like a leg cramp or having a pinched nerve. And you can detect, something that's really closely related to restless legs, and everyone who has restless legs have probably heard of this, but periodic limb movements. I'm going to show you a little video here that's sped up by about 6 times speed here. But you can see over here, this person is kicking their legs the whole night. You can see that. sometimes the leg kicking stops. Sometimes it's just the foot. Other times it's actually the full hip and knee kicking, but the leg is constantly kicking the whole night. These movements are called periodic limb movements in sleep. And you can only catch them really on a sleep study or using some other advanced methods. But there are these involuntary repetitive movements of the legs throughout the night. And it's estimated about at least 80% of restless legs have periodic limb movements, these leg movements that I just showed you the video of. But these periodic limb movements are actually seen in other various sleep conditions and medical conditions as well. So what are the other features for restless leg syndrome? Well, it improves with medications that increase dopamine. And again, the presence of periodic limb movements would be something that would be a feature for restless legs, as well as a family history. Some other features would be that it's progressive clinical course. Generally speaking, the neurological exam is normal, and there is an associated sleep disturbance. So what do you do about this? Other causes, secondary causes. So there are some what we call primary causes for restless leg syndrome, which means that it just comes out. Often those may be familial, sort of like genetic in nature, but other causes for restless legs can be pregnancy, especially as the pregnancy continues into the third trimester. This typically resolves after delivery of the child. Iron deficiency and anemia, very, very, very important to measure iron levels in people who have restless leg syndrome. Also, B12 deficiency can trigger restless legs or at least be associated with it. And nerve damage in the legs or in the back. Our medical terms for these are peripheral neuropathy or radiculopathy, or also kidney or liver disease as well. So how do you treat restless leg syndrome? Well, really important is to improve sleep hygiene. Really, really want to be keeping so keen on very, very, very careful sleep hygiene. Avoiding restless legs triggers, such as certain medications, which we can discuss further in the question and answer period, but things like antidepressant medications, even caffeine, nicotine, other substances like these stimulating substances can often trigger restless legs. We've published recently a paper in one of the neurology journals looking at all the medications that can actually trigger periodic limb movements and highlights and the worsened periodic limb movements can actually worsen the restless legs. Stretching exercises, massage, hot or cold baths, depending on the individual, and relaxation technique can also be helpful. If people have low iron levels, they actually need to check their ferritin levels. Ferritin is a blood test that measures your iron. We usually like to have a ferritin level of greater than 100 in patients with restless leg syndrome. So some people who don't have that may need iron replacement in the form of taking tablets or even IV transfusions of iron. Other medications, obviously, you need to get these through a physician's prescription. They wouldn't be available over the counter, but things like dopamine agonists, such as pramipexole or ropinolol, and a sample dose I've provided here is just a very, very, very tiny dose, very, very, very tiny dose, 1 to 2 hours before bedtime. Other things that have become popular in the recent years, maybe in the recent decade, has been the use of things like gabapentin and pregabalin, and occasionally we'll use clonazepam. But one has to be very careful that there's a decrease to this drug over time, a decrease in the response to this drug over time, and that's due to tachyphylaxis, a term that we call tachyphylaxis. So restless legs, as I've already alluded to, is really, really associated with poor quality of life. It's really disabling. But the question is it linked in any way to stroke and to other forms of vascular disease? So what's important to note, there's a lot of papers in the literature that show that both restless legs and periodic limb movements can arise after stroke. And this is work from our lab at Sunnybrook in the Sunnybrook Sleep Laboratory, where we basically took the MRI scans of patients who had a stroke, and we compared the people who didn't have restless legs to those who did. And if you look at the red areas over here, you can actually see that there's specific portions of the brain that we're able to clearly delineate that are associated, that are linked up with restless leg syndrome after stroke. Okay, so the blue areas are those people who didn't have restless legs. The red is the area where the patients did have restless legs, and they more or less overlapped in specific areas of the brain These areas of the brain are responsible for the pathways that mediate things like movements, sensation, and other important functions, and actually sensory and movement regulation. We also, this was some of my master's degree work that I did with my colleagues on the line, that we looked at how do patients do if they have restless leg syndrome after their stroke. And we showed that about a quarter of patients, about 24% of patients, reported restless leg syndrome symptoms after stroke. About half of these were brand new cases. About the other half, they had had restless leg syndrome prior to the stroke. But patients with restless leg syndrome, when we follow them over time, they actually had poorer quality of life, both at baseline and at follow-up. And these were numbers that were statistically significant and published in a respected medical journal. So I've just told you now that stroke can give rise to restless legs and periodic limb movements. Well, you're going to tell me, well, listen, I don't have restless legs. It's, and I hope that we all want to stay free of stroke. But the question is that if I have restless legs and periodic limb movements, and that might be the question in the back of your mind, if I have restless legs and periodic limb movements, can that actually contribute towards the development of stroke? And there are a bunch of different mechanisms that might be able to do it. So remember how I showed you that video of the gentleman kicking his leg nonstop back a couple of slides ago? Well, there's some evidence that perhaps these periodic limb movements might actually cause blood pressure to increase at night and cause people's heart rate to change. And having that fluctuation, that change and that increase in blood pressure and heart rate overnight might actually not be good for you. And there's some suggestion that perhaps the periodic limb movements that are linked up, these leg movements in sleep that are linked with restless legs, may in fact give rise to vascular disease like stroke and heart attack. There's also inflammation that's been shown to be associated. So if you look at blood tests, blood markers for restless leg syndrome, then in fact, it's been shown that those same blood markers in fact are linked with increased rates of stroke and other vascular disease. There's something called oxidative stress, another form of stress release molecules that also gives rise to, that also can give rise to stroke, and it's present in both restless legs and periodic limb movements. And then it's important to note that some common risk factors such as diabetes and obesity are mutually present in both restless legs, periodic limb movements, and stroke, as well as sleep disturbances, depression, and anxiety disorder, which we know both are closely linked with restless leg syndrome, periodic limb movements, as well as vascular disease. So this is some work we did that we showed that you can look at different studies in the literature, but what we did here is we looked at all the studies in the literature and combined them numerically together. This is what we call a systematic review and a meta-analysis. And what we did is, this was back a couple of years ago, but we took every single paper that studied the link between stroke, heart disease, also known as cardiovascular disease, with restless leg syndrome or periodic limb movements. And there was actually evidence, again, it was only 3 studies, so I don't want to overstate the claim, but an increased periodic limb movement index was actually linked with a higher heart attack risk and early mortality. Again, I don't want to overstate the risk. It was only 3 studies. The evidence that supported, however, restless leg syndrome with heart disease and heart attacks was actually mixed. There wasn't a clear association, and there was no clear association between restless legs and all-cause mortality. In fact, that relationship was not statistically significant. Another way, other than following thousands of people over time, you can actually do MRI scans, and rather than looking for big strokes that would, lob out part of the brain, you can look for like little dots. And in fact, these little dots here are called white matter hyperintensities, and they independently predict an increased risk of stroke, dementia, and death. And these, again, can be intermediate markers in the research setting. So again, these are the little bright spots, and we call them in the medical world white matter hyperintensities. So research that we published, again, members of this group and other groups around the world showed that both, if you had restless leg syndrome or periodic limb movements, you actually had more white dots, those white matter hyperintensities on your brain, which might suggest, again, a higher risk of an incident stroke, dementia, and perhaps early mortality. Again, the research in this area is still evolving. I want to talk about, I wanted to talk about links between other sleep disorders and stroke. Actually, part of it is I wanted to address some of the questions that we got, and thank you to everyone who provided questions. We're always happy to answer them. But if you look at shift work, I mean, I'm going to leave again Dr. Tandon to discuss sleep apnea. But if you look at shift work, in fact, shift workers, people who work overnight shifts or shifts that are outside of their normal circadian rhythms, like what Dr. Lim was alluding to, you can actually see that there's a higher risk of workplace accidents, type 2 diabetes, weight gain, coronary heart disease, stroke, and cancer. And all of these, this is well validated in the literature that in fact, shift work is shift work is actually harmful for your health in the long term. Likewise, insomnia, if one is unable to initiate or maintain sleep, this can, cause not only irritability, but also can cause, as Dr. Lim alluded to, troubles with objective and subjectively measured cognition, and also increases the risk of high blood pressure, coronary heart disease, recurrent coronary, basically repeat heart attacks and heart failure. And there's also a link as well in stroke survivors, and that the prevalence of insomnia is higher in stroke survivors compared to in the general population. Finally, one of the questions that we get asked a lot about, how much do I need to sleep? Now, general recommendations, particularly by national bodies emanating from the United States, generally recommend 7 to 9 hours per night. But if you sleep less than 6 to 7 hours per night, it's been shown to have increased risk for heart disease and stroke, increased risk of early death, diabetes, hypertension, weight gain, and obesity, depression, and even impaired immune function. So my point is, the list goes on, that healthy sleep is paramount to healthy lifestyle. Conversely, you might think that only sleeping too little is bad, but actually sleeping too much is bad as well, and it's linked with heart disease and stroke. So overall, I want to just conclude that restless leg syndrome is common. Restless leg syndrome may be linked, and periodic limitus may be linked with vascular disease. Observational work suggests an emerging link between stroke and heart disease, what we call cerebrovascular and cardiovascular disease in the medical terms. But a lot of work is needed further, such as prospective trials and randomized trials as well. And poor quality sleep, and overall the role of restless legs and periodic limitus in stroke remains relatively unexplored. But again, poor quality sleep is linked with an increased risk of stroke and a whole host of other medical issues as well. So thank you very much for your kind attention. And it's been, again, a real pleasure to talk this evening. Happy to take your questions afterwards.
Thanks very much, Dr. Boulos. Next, I have the pleasure of introducing our final speaker for the evening, Dr. Anu Tandon, the Division Head of Respirology at Sunnybrook, who will be presenting on sleep apnea and your health. Dr. Tandon is a respirologist and sleep medicine specialist here with a focus on respiratory care of the neuromuscular patient, where she's involved in clinical research and practice guideline development in this population. Dr. Tandon is assistant professor at the University of Toronto. She is an honorary neurologist. She does so much work in this field that we're happy to have such a great colleague. Just a reminder to everyone online, please send us your question through the website if you have any. Dr. Tandon, the microphone is yours.
Wonderful. Thank you so much, Dr. Murray, for the introduction. So I am the last speaker this evening. So I'm essentially going to go over obstructive sleep apnea and your health. And I'm going to talk a bit about sleep apnea and trouble breathing during sleep, specifically beyond snoring. I'm also going to try and elaborate on a few things that Dr. Boulos and Dr. Lim have already gone through as well. As Dr. Murray mentioned, I am a respirologist. I'm not a neurologist. However, my area of specialty is breathing issues related to breathing muscle weakness. And so I work very closely with patients with neuromuscular diseases like ALS as well as multiple sclerosis. And so today I'm going to talk about a few things. So what's to come? So first of all, I want to talk a bit about the different types of sleep apnea. Often terms are used when you're sitting in an office going through sleep studies with your physician. And so I want to make a point of explaining a few of those terms. and then talk a bit about diagnosing sleep apnea. I know Dr. Lim as well as Dr. Boulos talked a bit about it. I want to show you some of the raw data that we get and how that translates to us actually identifying sleep apnea. I'll talk a bit about why sleep apnea matters and why should you look to investigate this further, and talk a bit about kind of the evidence and the research that's really exploded over the last 15 years, bringing a lot of this to light. And then lastly, talk a bit about treatments and how do you reduce your risk of sleep apnea. So what is obstructive sleep apnea? So you've actually seen this diagram, I think with Dr. Lim, but very simply, it's just recurrent episodes where your upper airway obstructs, causing awakenings from sleep and drops in your oxygen level. One of the very common questions that I get asked is, well, I get a lot of nasal congestion. If I fix the nasal congestion, will my sleep apnea go away? And I find this diagram really helpful because it shows exactly where the obstruction occurs. It's very much at the back of the throat, as opposed to it being nasal, that leads to the obstructive sleep apnea. Another term that a lot of people hear about is central sleep apnea. And what central sleep apnea is, in very kind of simple terms, is when the brain forgets to tell the lungs to breathe. And that could be related to medications, but it can also be related to the brain not getting the signal fast enough to tell the lungs to breathe. And that's something that you often can see in patients with heart disease. It's not very common. It's not as common as OSA, which is obstructive sleep apnea, but it's something to keep in mind, particularly in patients who are on pain medications, as well as who may have underlying heart disease. As a sleep physician, it's something that we look for, particularly in patients with that background. So how do you diagnose sleep apnea? So there's been a lot of discussion about sleep studies. And, this is a woman sleeping very comfortably and asleep in bed, wired from head to toe. And it is remarkable how we want patients to sleep with these wires from head to toe, and we examine quality of sleep and sleep apnea using all of these wires. What's good to know is that, particularly for sleep apnea, and I'm only going to talk about that, is that a lot of the findings that we look for in a sleep study are very objective, meaning we look at the stoppages in breathing, and I'll talk about that. We look at airflow, we look at oxygen levels. And so the majority of people who go through the sleep lab may come out in the morning saying, I just didn't have a great night's sleep. I don't even think I slept. And that could be the case, that the quality of the sleep may not be as good. However, the data that we're looking for, particularly for sleep apnea, can still occur even though you may not get the best quality of sleep. And that's often another question I get asked, well, doctor, how am I going to sleep with all of this? Are you going to get any data? And usually we're able to do so because even though you may come out of the sleep lab feeling unrefreshed, we were able to capture data. And the data that we capture looks like this. And so it's a lot of lines and it looks very complicated, but this is essentially the outcome of your 4 to 6 hours of sleep in the sleep lab. So there's wires on the brain to tell us the different stages of sleep you go through in your brainwave activity. It tells us when you're waking up. It tells us when you fall asleep. We also monitor the muscle tone in your body. We look at your ECG to look for any abnormal heart rhythms at night. We look at leg movements, which Dr. Boulos spoke about. And for me, I'm very much interested in the oxygen levels, the carbon dioxide levels, the airflow in and out, and how well your abdomen is moving and your chest is moving in response to your breathing. All of that information, about 4 to 6 hours of data, gets collated and run through with a sleep technologist who goes through all the data, and they generate a sleep report. And that sleep report is subsequently interpreted by your sleep physician. From a sleep apnea standpoint, one term that you may have heard of, or your doctor may sit down with you when they're going over your sleep study, is, well, how many times an hour you stop breathing? The technical term for that would be your apnea-hypopnea index, and it's really the number of apneas and hypopneas per hour. And so we take your hours of sleep and we divide up the events and we come up with that number. essentially the apnea-hypopnea index is lumped together, but there are definitions for each of these. So an apnea is where you completely stop breathing for a minimum of 10 seconds, versus a hypopnea is what you can consider a milder form, where you don't completely stop breathing, but you start shallow breathing for a minimum of 10 seconds. And that's usually associated with either an awakening from sleep or a drop in your oxygen level. And so as physicians, we're looking for that number to see if you have sleep apnea. The number that we look for is anything more than 5 per hour is what we would normally use to diagnose sleep apnea. So why does sleep apnea matter? So that, as I mentioned in the introduction, is that there's been just an incredible amount of information on sleep and quality of sleep and how it can affect your general health. Both my colleagues, Dr. Boulos and Dr. Lim, spoke about that. The same is happening from a sleep apnea perspective, as we know that sleep apnea can affect your mood. It can affect your metabolic health, such as diabetes. It can affect your risk of developing heart disease or heart failure. It can also affect your memory and can affect your blood pressure. So I'm going to talk a bit more about that. So sleep apnea and memory. So we talked a bit about, I mentioned that we put all the wires on the head to tell us the different stages of sleep you go through. One of the stages that we're most familiar with is something called REM sleep. And it's the period of night. It has a number of functions. One of the most important functions that it plays is it helps in forming memories and acquiring knowledge. So that happens during REM sleep. As a respirologist, it's important to me as well, because I also know that if you're going to have sleep apnea or if you have breathing muscle weakness, I know your breathing is going to be worse in REM sleep, because that's also the time of night that you lose muscle tone. Studies have shown, particularly from a memory perspective, is that if you have sleep apnea that's severe enough, you may develop cognitive decline at an earlier age. Again, these are some studies that have signaled this. And there's some studies that might show that if we treat that sleep apnea, we might be able to slow the progression of cognitive decline. And so particularly at Sunnybrook, which is a huge center, a huge memory clinic, we see a number of patients that come through our clinic specifically with this question who have been diagnosed with dementia. And you've seen that alluded to both in Dr. Boulos and Dr. Lim's presentations, specifically to look for any sleep disorders that could be potentially contributing to this. And is there anything preventative or any secondary prevention that we can do to try and slow things down? There was some discussion about heart as well. And so in patients who develop sleep apnea, there's been numerous studies dating back to the 1990s that have actually shown that if patients have a high, moderate, severe degree of obstructive sleep apnea, their risk of developing high blood pressure is increased. And so the thoughts is that moderate, severe, untreated sleep apnea is a risk factor for developing high blood pressure. And essentially why that happens is that every time you have a stoppage in breathing at night that's abnormally high, we alluded to the apnea-hypopnea index, which was the number of times an hour you stop breathing. And I mentioned anything greater than 5 was abnormal. Anything greater than 20 has been shown, 20 per hour, has been shown to be a risk for developing high blood pressure. So anytime you have these stoppages in breathing, there's a surge in a certain hormone that essentially causes your blood pressure to go up. If that happens repeatedly throughout the night, you can actually get remodeling in the blood vessels and ultimately develop high blood pressure. So we know that if we keep those hormonal levels down and we reduce those surges in blood pressure, we can treat some of the high blood pressure, but more importantly, prevent it from occurring in the first place. We also know that diabetes is a risk factor for developing heart disease. And so there's been quite a bit of work recently looking at how sleep apnea can affect metabolism. So there's been studies that have looked at insulin resistance. So in patients who are diabetic, particularly patients with type 2 diabetes, they have insulin, but their insulin doesn't work as well. And so they develop a degree of insulin resistance. And interestingly, there's been work looking at particularly animal models with obstructive sleep apnea. And they've seen how over time, if you have a moderate severe degree of sleep apnea, you can develop insulin resistance, which can increase your risk of developing diabetes. We also know that sleep apnea has been, in general, linked to increased inflammation in the body. And that's been the link with stroke that Dr. Boulos was alluding to as well, is that there are certain inflammatory markers that are elevated in patients with moderate to severe degree of sleep apnea that can increase your ability of getting blood clots. And that's one of the mechanisms that's thought to increase the risk of stroke. Interestingly, there's more and more literature talking a bit about hormonal levels that can affect energy regulation and appetite control. And that, and I'll talk about this shortly, but that weight gain is a risk factor for developing sleep apnea. But there's some literature to say, well, if you have moderate severe degree of sleep apnea, then it might actually be harder to lose the weight. And it kind of goes back to that hormone I was talking about, cortisol, which can kind of lead to these surges in blood pressure. And that might actually make it harder to lose weight. And if we treat the sleep apnea, we may have a better chance of losing weight. That story is still unfolding, but there's definitely some literature indicating that. If you tie it all together, it can get very complicated, but sleep apnea has been shown to play a role in heart disease in general. And so if you look at this chart where if a patient has moderate severe degree of sleep apnea, there's a number of disease mechanisms that can occur. That was cortisol, sympathetic activation. It can lead to high blood pressure. We talked about it can lead to diabetes. We talked a bit about stroke. One of the other, Sunnybrook has a large electrophysiology center from a cardiac perspective, and there's a number of patients with complicated abnormal heart rhythms who are being managed at Sunnybrook. I see a number of those patients because it's thought that those same surges in cortisol can prevent patients from staying in a regular heart rhythm. And so that's another group of patients that we commonly take care of and particularly look for sleep apnea, because we know that if we can help treat a moderate degree of sleep apnea, we can keep these patients in a regular heart rhythm. Finally, why is it important? So this has already been alluded to, but one of the most common reasons for patients to be referred is not because the patient themselves, but perhaps a bed partner has been awake at night, nudging them because they see them stop breathing, or there's a significant amount of snoring. As much as I said that I wanted to look beyond snoring, it's hard to ignore it when it's really the largest reason for referral, and not necessarily the patient, but mostly the bed partner complaining. So how do you reduce your risk of developing sleep apnea? So first and foremost, lifestyle changes. So there's changes that are within your control, and then there's obviously some changes that are not. And so when we look at lifestyle, one of the first reversible risk factors that we have is weight. And I see a number of patients who've spent years trying to lose weight and have developed significant sleep apnea. And we know that weight gain can lead to increased severity of sleep apnea, and by the same token, weight loss can improve the severity of apnea. And there were questions that I think we will be getting to regarding weight and sleep apnea and treatment options, and I'll try and address that later as well. We know that increasing alcohol intake before bedtime can lead to worsening muscle tone, and over time can lead to weight gain as well. So reducing alcohol intake within 3 to 4 hours of sleep can help with the severity of sleep apnea at night. There's certain medications that lead to reduced muscle tone that can also lead to increase the risk of developing sleep apnea. And I kind of threw in positional therapy here, and I'm going to elaborate on that, but that there are some patients whose sleep apnea is only on their back. And you may be told by your doctor in a very primitive fashion to put a tennis ball on the back of your t-shirt. So every time you're on your back, you flip over to your side. And if you Google positional therapy, there's tons of stuff on the internet that's being sold, the anti-snore shirt, etc. But I put this in here because I considered it a less invasive way of treating sleep apnea. So how do you treat sleep apnea? So the gold standard and mainstay therapy is really positive airway pressure, of which there's several types. CPAP, which in long form is continuous positive airway pressure. Often patients kind of lump the masks and the CPAP together. This is the CPAP, this is the mask. There's a huge number of types of masks with the nose, over the mouth, over the face, that patients can choose. The key to CPAP use is, interestingly, not the machine, but the mask. The machine does play a role, and I'll talk a bit about the other two devices that I've mentioned here, but it's really finding a mask that's comfortable and working closely with your CPAP company to find that mask. And that was tricky during COVID because a lot was being done virtual. Now that patients can actually touch and feel and put a mask on, it's definitely much easier. There's some terminology called an APAP. Some of you may have heard of that. That's considered an auto device. It is similar to a CPAP in the sense that it delivers one pressure whether you breathe in or you breathe out, but it will fluctuate pressures based on your stoppages in breathing. So when we prescribe these devices, we give a range. There's something called BiPAP, which I do prescribe quite a bit for patients specifically with breathing muscle weakness, but also those individuals who've either tried CPAP and not found it comfortable, or patients who've just required very high CPAP pressures that they weren't able to tolerate them, and then we've gone to BiPAP. There's also dental devices. So these are done by dentists. They're essentially molded to the mouth. And the goal of these devices is you pop them in at night, they bring your lower jaw forward and open up your airway. And by doing that, they treat your sleep apnea. This is considered second line therapy. So if you're not able to use CPAP, or you've failed CPAP, or you have some sort of structural defect that won't allow you to wear the CPAP, we go to the oral appliance. This is done by dentists. It's not covered by OHIP. It's one of these devices that if you have a mild degree of sleep apnea, positional sleep apnea, and you're not particularly overweight, it could be an option to treat the sleep apnea as well. I put ProVent up here because I get a lot of questions about ProVent, and a lot of patients still ask for it. And it is a device that you put into your nose, and they're like one-way valves, and you can breathe. Essentially what it does is you can breathe in, but when you breathe out, it closes at the end of breathing, and it stents open the airway. You use a new pair every night. I do have to say, and I think my colleagues might agree, at about 5-6 years ago, this was the rage. Everyone was asking about it. It's fallen out of favor now. I have less patients asking about it because it's been fairly, A, it's expensive, and B, for those individuals who mouth breathe or have a significant amount of sleep apnea, this was just not an option, and it didn't really do the job. There are a number of surgical options available, and that's a whole talk in itself. So there's a lot of nasal surgeries. There's jaw reconstruction. There are nerve stimulations, hypoglossal, so nerve stimulations to keep the airway muscles tight. Surgical options, take out the tonsils, laser the back of the throat, including the bob in the back of the throat, which is the uvula. And all of these can be done by particularly oral surgeons who specialize in this area, or ENT physicians. Not all of these are available in Canada, but these are all being surgical options that are being considered. There was discussion about upper airway muscle exercises and sleep apnea. And for anyone who may be familiar, this is something called a didgeridoo. This was a study that was published, oh goodness, about 10 years ago, 8 years ago. Dr. Boulos might be able to help me with that one, but it was essentially looking at the didgeridoo and those individuals who use the didgeridoo every day, and looking at strengthening of the muscles and whether it helped from a sleep apnea standpoint. And so I put this up there just in case anyone had seen that study. So there are exciting things to come. And in my area of expertise, as I mentioned, is that I'm fairly subspecialized with regards to specifically breathing muscle weakness that can occur in patients with neuromuscular disease. And as an honorary neurologist, I'm part of one of the largest neuromuscular clinics in North America, where I particularly work with individuals with muscle weakness related to their breathing muscles. And as I mentioned, this particular group is significantly affected not only by sleep apnea, but essentially something called hypoventilation, where you're just not getting in enough air, so not enough oxygen and not breathing out the carbon dioxide. And so right now, we've been very fortunate to be involved in a multi-center provincial-wide study where we're testing a virtual platform to monitor these patients in the home, because as you can imagine, a number of them have mobility challenges, but also to monitor their ventilators in the home. And this was something that we were actually looking at before COVID. And the funding was accelerated during COVID, so we were able to onboard a number of these patients. And so we're in the thick of it now, and we've been recruiting a number of patients on ventilators in the home, and it's been wonderful for patients. They've really enjoyed being able to virtually communicate, and while we found other means to do it, is actually monitoring the ventilators in the home, which was something that we were not able to do prior to COVID. And so it'd be interesting to see what the results show in the next couple of years. So to summarize, as I mentioned, there are predominantly two types of sleep apnea. The gold standard is still the overnight polysomnogram. As Dr. Lim alluded to, there are definitely different testing in the works, and we're looking forward to bringing those to fruition, because it is an expensive test and it's a cumbersome test, especially for patients with mobility issues and those individuals, even with some cognitive decline. There's increasing evidence that sleep apnea can affect memory as well as your heart, that there are reversible risk factors, including weight and alcohol consumption, as well as smoking, and that there are a number of treatments for sleep apnea. However, the gold standard still remains positive airway pressure therapy. And thank you.
Thank you very much, Dr. Tandon. That concludes our formal presentations, and we'll now begin the question and answer portion of the evening. If you'd like to submit a question to one of our panelists, you can still do so. We have quite a few questions, and so we'll work through them. We won't be able to get to all of them, but we'll take an attempt at some of the top items. One question just in general that came in was how do I register for the sleep clinic at Sunnybrook? And the short answer there is to have your family doctor refer to one of us. And we may redirect based on our niche expertise. And we have other collaborators in our group that we work with as well to help manage the demand. So we'll start off with Dr. Lim. The question is, why am I tired when I retire to go to sleep, but then wide awake when I hit the pillow?
So this is actually a surprisingly common experience in folks who have insomnia. I mean, there are a whole host of possibilities here. You know, one possibility, and in many patients that I see, they've come to associate the being in bed and the sleep environment with something other than being sleepy, right? For some people, it's because they've perhaps used their iPhones in bed or get work done in bed, and have come to associate the bed, in fact, with getting work done. So you wake up as soon as you lie down, because it's kind of like being in the office. And for other folks, if they've had insomnia for a very long time, they've maybe even come to associate the bed with the experience of insomnia, with the frustration of not being able to fall asleep. So oftentimes this sort of experience is a sign of some sort of a activating or negative association between the bed environment and just being awake and being activated.
One question that just came in, if you can't get 7 to 9 hours of sleep a night, Dr. Boulos, is it better to take a sleeping pill and get the sleep, or just go without the 7 to 9 hours of sleep?
Mm-hmm. Thanks, Dr. Murray. Yeah, so that's a great question. Every one of us is different. Some people need less than 7 to 9 hours of sleep to be healthy, basically less than 7 hours of sleep. But under those circumstances, it's really important to get checked out by a sleep specialist. Make sure you don't have an underlying sleep disorder that's actually making it difficult for you to get the generally recommended 7 hours at least of sleep per night. Also, then that also highlights the role of sleep hygiene, like what Dr. Lim was also just alluding to. Are you using your cell phone in bed? Has the bed become associated with non-sleep activities? how much you're eating, drinking before bed, are you drinking right up close to bedtime? And there's a whole host of sleep hygiene things that, that are super important. Alcohol, stimulant medication before bed. Again, there's a whole host of things that really can improve the quality of your sleep that are simple, straightforward advice that can tidy it up. But again, those things would be best addressed through a sleep clinic.
A follow-up question from the audience. I have read that CBD oil can help sleep. What are your thoughts on this, Dr. Boulos?
Yeah, so there's growing literature and growing evidence that perhaps CBD can help a number of different medical issues, including pain. And there is some evolving evidence, for example, in the restless leg syndrome world, that restless legs may actually be aided by cannabis as well as in cannabinoids. Likewise, some literature, I can tell you anecdotally, I had some patients with refractory insomnia. When they tried CBD, they actually did improve. So there might be a role there as well. And in our work, actually, in fact, we are studying in our group, in our research work group here, we are studying the relationship between sleep apnea and cannabis use. So there are a lot of real exciting research. I know Dr. Lim alluded to some real cool research as well. But the Sunnybrook Sleep Lab is, trying to go up, one step ahead and trying to explore these exciting things. And there may be a role for cannabinoids for the treatment of sleep apnea as well. So again, exciting stuff.
Dr. Tandon, I did a sleep study in 2016 at Sunnybrook. Results were mild sleep apnea. Should I have another sleep study? I'm 75. Does sleep apnea get worse with age?
Thank you. So sleep apnea can get worse with age. The question of whether you should have a repeat sleep study really depends on a few things. So one, I would argue that weight gain is likely a greater risk factor for developing worsening sleep apnea. But the bigger question is are you symptomatic? So are you having worsening symptoms of sleep apnea? And is there been any changes in your sleep? Or any changes in your general health? So we spoke a bit about the risk factors of moderate to severe degree of sleep apnea. But I would argue if your symptoms have changed, if your underlying health has changed, or you've gained weight, those would likely be more reasons to get a repeat study rather than age alone.
Dr. Lim, is it safe to take melatonin 5 milligrams every night to get a good night's sleep? Are there any side effects?
Sure. I mean, I think the first thing to do is to ask, whether melatonin is really necessary or helpful in any particular situation. So in general, for garden variety insomnia, melatonin actually isn't all that effective and may not be particularly beneficial. I think melatonin's definitely helpful for some forms of circadian rhythm disorder. So nighttime melatonin, for instance, is helpful in delayed sleep phase syndrome, for instance. So I think the first thing to do is to ask whether the melatonin is likely to be beneficial for the particular type of insomnia that you have. In cases where the melatonin is beneficial and there's a good reason to be taking it, we do have randomized controlled trials that are months in duration that suggest that melatonin, at least for many months of use, doesn't seem to have significantly more side effects than placebo. So it appears to be well tolerated for that. For longer durations of use, we don't have long-term randomized controlled trials to compare melatonin, for instance, to placebo for years of use. Anecdotally, I think it is actually fairly well tolerated for prolonged use in, for instance, people who have circadian rhythm disorders. And if you do have one of these circadian rhythm disorders, if you have delayed sleep phase syndrome, on balance, melatonin, if it's an important part of managing that, is probably going to be more helpful than harmful. But it's really something you got to weigh on an individual case basis. I wouldn't say that blanket use of melatonin in the long run for all cases of insomnia would, for instance, be a useful way of managing things.
A follow-up question. If I use a full spectrum light to aid sleep, should I use it in the morning or at another time?
Right. So it really depends. So it really depends on the nature of the circadian rhythm abnormality. If you have advanced sleep phase, like Beatrice did, then nighttime phototherapy is actually what you need. In fact, morning phototherapy would be harmful for somebody like Beatrice. On the other hand, if you have delayed sleep phase syndrome, which is the opposite of what Beatrice had, then it may be that morning phototherapy is beneficial. So I think it really depends on the nature of the underlying circadian abnormality.
Dr. Boulos, does a lack of sleep and or bad sleep habits contribute to weight gain?
Yeah, they do. So, so basically, you can think almost of sleep as having, it provides your body with energy, but so does food. So if you are sleeping insufficiently or having poor quality sleep, your body doesn't have that rest and that energy to metabolize food effectively. Also, taking food late at night, the body is also metabolizing the food less effectively. So a lot of people who eat overnight will, in fact, that activity is associated with greater weight. So is sleeping an insufficient duration.
This food theme leads us to a question for Dr. Tandon. Does diet have an effect on the quality of sleep? And if so, how should we modify our eating habits for the most ideal sleep experience?
So I think it's, just an extension of the previous answer as well, is that eating late at night can lead to weight gain, which we alluded to is obviously a risk factor for sleep apnea. I apologize, the second part of the question.
If so, how should we modify our eating habits for the most ideal sleep experience?
Sure. So, I think by virtue of knowing that eating later at night can lead to weight gain, then I often tell patients to try and move their meals further away from bedtime. There's also some questions about kind of waking up frequently at night to urinate. And, while there could be other medical reasons why that could happen, drinking a lot of fluids prior to bedtime can also lead to poor quality sleep and sleep disruption as well. So that's normally what I recommend with my patients. And those individuals on CPAP, for specifically, I say not to be eating so close to bedtime because it can be uncomfortable as well.
A follow-up question, Dr. Tandon, please address the relationship between sleep apnea and acid reflux, gastroesophageal reflux.
Sure. So acid reflux won't cause sleep apnea necessarily, but uncontrolled or untreated sleep apnea can lead to increased risk of developing acid reflux. And it really just has to do with the fact that you have the repetitive closure of the upper airway, and that can cause essentially, it can worsen acid reflux and cause the symptoms related to acid reflux or GERD. We know that if you treat sleep apnea, there's been some studies that have shown that the amount of reflux goes down, and as given that the symptoms improve as well. And so that's what the literature so far has shown.
Who would be best to diagnose and treat acid reflux? What type of specialist?
Yeah, and I'm starting with the, because I think that there's it's important to see the family physician, make sure there's nothing else going on, make sure there's no medications that could be causing these symptoms, and see if there's anything modifiable. Ultimately, a gastroenterologist is someone who can get involved if the acid reflux is complicated and if further investigations are needed. But I always recommend speaking to your family physician first.
Dr. Lim, a question came up. My urge to urinate is 2 to 3 times per night. My sleep hygiene is good. I go to bed at 10 and up at 7. I try not to drink a lot of fluid, but it doesn't seem to help. Please advise.
Yeah, sure. So, I mean, certainly, if you're peeing a lot at night, one possibility is that there's a fundamentally a urinary problem, right? So guys with big prostates, for instance, pee a lot, right? So it could very well be urinary or related to other medical problems that result in excessive urine production, for instance, taking like diuretics and pills that make you pee more. So it could like peeing more might just be a pee problem, is one thing. But on the other hand, it's also true that if you wake up for any reason, you're more likely to be aware of the need to urinate and therefore go to the bathroom, right? So we commonly see, for example, sleep apnea being a cause of repeated nighttime awakenings. You wake up because you have the apnea, because you're awake, you realize you need to pee, and then you go pee, and then you go back to bed. And you think, well, maybe it's the pee that made me wake up. But the proof is in the pudding. And sometimes if you take a patient with sleep apnea and treat their sleep apnea, the frequent nocturnal urination vanishes. So sometimes pee problems can be a pee problem. Sometimes what it is you waking up for some other reason and therefore urinate.
Follow-up question. Why do I have difficulty getting back to sleep after I get up to use the bathroom at night?
Yeah, so a couple of things. I mean, sometimes if you end up waking up like a ton of times, eventually you wake up at a point in the night when you've already bled off a lot of sleep pressure, right? So you've already, slept for 5-6 hours. You're not half as tired as you were, 5 or 6 hours earlier. And at some point you just can't get back to sleep. So that's one possibility, especially for awakenings later in the night. It could be that you have some other reason why you're waking up early, like Beatrice, for instance, had a circadian rhythm problem. And it could be that some of the awakenings, or many of the awakenings that she had, were due to sleep apnea or something else. But eventually, the reason why she just simply can't get back to sleep at 4 a.m. is because her body clock is really advanced, right? So I think it depends a little bit on when the awakenings are happening, the nature of the difficulty getting back to sleep, and a whole host of other factors. But I think there are many possibilities for this.
Dr. Boulos, I have restless legs, and nothing my sleep specialists have prescribed or told me to do has helped. I take pramipexole or Mirapex in the evening. I increased my ferritin level to over 100, taking iron, take various vitamins, and my legs are still so jumpy, twitchy, painful, crampy, and uncomfortable in the evenings. What are your thoughts?
Yes, I'm first of all, I'm sorry to hear that you're going through all this. But we certainly can try to help you out here at Sunnybrook. When I get a referral or a patient like that, I take a step back and take a look at everything that's potentially contributing towards sleep. So is the sleep hygiene optimized? Are you taking any medication? So it's unknown to a lot of people, sometimes even physicians, about which different medications can worsen restless leg syndrome. I had a patient recently who was taking cannabis, but in fact, the cannabis was spiked with some nicotine, and that nicotine itself, it wasn't necessarily the cannabis or the CBD that was worsening things, but it was actually the nicotine. So really careful on things like nicotine intake, caffeine, other medications. Do you have another medical condition? Sometimes after you've addressed all those things and still can't get under control the restless legs, is there something wrong with the back, with the nerves that are running through the legs from the back, or even the legs themselves? And so these are all things that we would evaluate very carefully. And as Dr. Murray and Dr. Lim alluded to before, and Dr. Tandon as well, one could be referred if they're having a specific trouble with their sleep to the Sunnybrook Sleep Laboratory.
Dr. Tandon, Dr. Lim has commented on why quality of sleep reduces as one ages, but particularly for postmenopausal women, what's going on there?
Yeah, so postmenopause, the thoughts is that obviously a lot of the hormonal changes can lead to poor sleep. And so, one of the more common things that patients discuss is something called hot flashes, is that I get these hot flashes and I wake up. And what's interesting is that studies have actually shown that the part of the brain that causes the hot flashes is actually the part of the brain that will actually lead to awakenings from sleep. And so it's kind of the same conversation about you wake up and then you urinate, is that some studies have shown you wake up and then you have these hot flashes. And so, that's part of it. But interestingly, there's also been studies that have shown that your risk of developing sleep apnea post-menopause is higher than pre-menopause. And that as a postmenopausal woman, you're 3 times more likely to get sleep apnea than you did pre-menopause. And this is completely independent of body mass index or weight changes. And there's been some really interesting studies that have actually looked at upper airway muscle tone in women who are postmenopausal, and then provided, and these studies are quite old, but that if you replace some of the hormones, then there's been improvement in the muscle tone. And so there's been physiologic studies that have shown clearly why there's an increased risk of sleep apnea. The other thing is, and this is something that was alluded to before, is that as you get older, you start to develop more medical conditions that can affect your sleep. You end up on medications that can also affect your sleep. And so I think all of those in combination are likely contributing to kind of more sleep disruption postmenopausally.
Dr. Lim, why is sleep so easy to attain for some people, whereas others struggle to fall asleep?
Right. So, I mean, certainly it could be that some people just have sleep disorders, things like restless legs or insomnia, circadian rhythm disorders. So I mean, I think sleep disorders account for at least some of the difference between good sleepers and bad sleepers. Some of this is genetic as well, right? So I think even in the absence of an identifiable sleep disorder, in the absence of a circadian rhythm disorder or restless legs or something like that, or sleep apnea, there are, pretty profound inter-individual differences in the depth of one's sleep, the quality of one's sleep, even in the sleep EEG, right, and the electrical features of sleep that appear to be genetically determined. So, yeah, I think there's a certain layer of normal variation in sleep depth, sleep duration, sleep need, and sleep EEG, superimposed over top of which there's a layer of of identifiable sleep disorders.
Dr. Boulos, a question comes in. I find that if I eat something just before bed, I seem to settle and I'm more ready to rest. However, that I find I'm awake again. As well, I watch the national news before bed. Is that a bad thing?
Yeah, as I think Dr. Tandon had alluded to a few moments ago, eating a meal right before bedtime is not good. And I think I might have answered part of this as well. That eating a meal before bedtime is not great, like a full meal. Some people, though, will take, maybe a warm cup of milk or something that just makes them sleepy. But again, we generally say avoid fluids and really meals before bedtime by a couple of hours, just because, again, the body doesn't metabolize those quite as well. In terms of the television just before bed, there is some research that suggests that if you're exposed to electronic screens and television and so on 30 to 60 minutes before bedtime, then it can actually cause a little bit of insomnia and that you have a harder time falling asleep. Why does that happen? That happens because light actually activates a circuit that connects between your eye and the awakening portion of your brain. It's called the hypothalamus, this retinal hypothalamic pathway. So again, the general recommendation is to avoid screens and electronic devices. Definitely no use of those in the bedroom itself for the reasons that Dr. Lim mentioned, that you don't want to associate the bedroom with anything that isn't sleep or sex. But however, we even say before going to bed, ideally you would be free of electronic screens 30 to 60 minutes, at least 30 minutes before bedtime. Now, that may not be practical for everyone. I've had some positive experiences with some of my patients in using blue light blocking glasses. So there's little glasses that you can wear, and they in fact block the ray of the light that is harmful towards your sleep, and that may help people fall asleep a little faster should this be an issue for you.
Dr. Tandon, can weight loss eliminate the need for CPAP? If so, how much loss? And must one be below a particular level at a particular age?
Yeah, so I spoke about how weight gain is a risk factor for sleep apnea. And by the same token, weight loss can improve the severity of sleep apnea. Now, the question specifically, I guess, is about if patients can come off CPAP if they have sleep apnea. And so when you think about that, it's really important to focus on a couple of things. So one is that sleep apnea can be related to weight, but it can also be related to the upper airway architecture. And so some patients may have a more narrow airway that's easily collapsible and can lead to those repetitive closures that we discussed. And so in patients who are looking to lose weight to treat their sleep apnea, one of the main things that I do recommend is that it's very important to get a sleep study after you obtain that ideal body weight. Now, I put ideal body weight in quotation marks because the one measure we have is body mass index. And as you know, a normal body mass index can be anywhere from 18.5 to, I think it's 24.5. And so that's the range that you strive for. Now, body mass index is height versus weight. It doesn't account for a number of other features such as neck circumference. So you can be a perfect body mass index, but your neck circumference can be elevated. It doesn't account for waist circumference, which is a measure of cardiac health or risk of cardiac disease. But based on that, the goal would be to try and get to your ideal body weight. And that's something you need to work closely with your family physician on to get there slowly and get there in a healthy fashion. Whether that would be enough to treat the sleep apnea or come off the CPAP is, again, very much dependent on whether your sleep apnea is fully weight dependent or whether there's an upper airway architecture issue that could be contributing as well, which is less reversible.
Dr. Lim, I'm a fairly active senior, 81, who has no trouble falling asleep by 10 o'clock each evening. My problem is that I wake up around 3 a.m. and have trouble falling asleep until 4. I realize I have some sleep apnea, but I wonder if there's anything I should do to prevent this wakefulness.
Sure. So, I mean, there's a bunch of possibilities here. I mean, some of what you're describing here sounds a little bit actually like my patient Beatrice, right? Falls asleep easily at the beginning of the night, wakes up relatively early. So I think the possibility of an underlying circadian rhythm disorder, in addition to everything else, is there. The sleep apnea is, may very well be making a contribution, right? So sleep apnea will tend to wake you up. It'll tend to be more severe later on in the evening when you have more REM sleep. So having these kind of, awakenings in the latter half of your sleep period wouldn't be unusual for that as well. I mean, I think there's a bunch of stuff that might be going on here, and I think it's important to get it checked out and consider all of these possibilities.
Dr. Boulos, a participant writes, I developed atrial fibrillation approximately 2016 and had restless legs until 2012, from 2012, when I began taking escitalopram. I'm a 67-year-old male. This year, I've gained 30 pounds. Will losing weight help my restless legs and stroke risk? One problem for my weight loss, exercise triggers my arrhythmia.
Yeah, so that's a great question. A lot of different components we can talk about. So first of all, the restless legs may be actually secondary to the use of escitalopram, which is a class of medication known as SSRI. And it's known that SSRI medications, not only escitalopram, but others in that same group, can actually increase the risk of restless legs as well as the leg movements and sleep called periodic limb movements. So in some cases, we'll actually switch that medication. Again, that's not something you do at home on your own. I would highly recommend you see a physician and maybe the doctor who started on this escitalopram to see if that could be switched to something else. Now, the weight loss is beneficial because weight loss is closely because restless leg syndrome and actually sleep apnea are very closely related. So if you have bad sleep apnea, your restless leg syndrome can be worse. And in fact, sometimes the best treatment for restless leg syndrome, in fact, is CPAP. So losing weight could be good and could be beneficial through that way. Exercise plays a contribution towards weight loss. However, a larger contribution is actually dietary changes, in fact. So weight loss can help you, exercise can help you lose weight, but you're actually going to probably be more successful with dietary changes. And I would encourage light exercise. If you can't do strenuous exercise that may be triggering arrhythmias, I would recommend light exercises, again, under the guidance of your cardiologist, because exercise itself has a whole host of beneficial benefits for your overall health, aside even from sleep.
Dr. Tandon, I have a 9-month-old baby who wakes up a few times at night and my sleep is very light. How can I ensure I'm getting the proper amount of sleep? Any tips?
Oh boy, that's a good one. That's a great question. And I think anyone who's had children can definitely sympathize with you. It's difficult. It's very much a similar conversation with shift workers who, they don't have a lot of flexibility. This is what they are having to deal with, and a lot of the disruption is out of your control to a certain degree. I think if you have the ability to get this sleep at times where, at times where the child is sleeping as well during the day, and be able to catch up on sleep, I think that would be helpful. But it's difficult I think it's a difficult time to be able to ensure that you're getting enough sleep. But I mean, my advice would be to try and sleep during the day to make up for the lack of sleep at night, if you have the ability. It can unfortunately disrupt your sleep cycle, and Dr. Lim might be looking at me going, "No, you don't sleep during the day." But realistically, you have to sleep when you can, specifically in the situation that you've asked about.
Get your sleep when you can.
Yeah.
Dr. Boulos, I take a sleeping pill, trazodone, occasionally, and find my restless legs is more severe. Is there a link?
It's interesting because as this question came in, I was just searching for that. My own clinical exposure, trazodone is not, doesn't worsen or improve restless leg syndrome. However, when you look into the medical literature, which I was just going through right now, there are actually case reports where trazodone hasn't helped people and has worsened people. So I think it can go both ways. Again, I would just highlight the importance of looking for other triggers as well, because it may not be, when there's mixed literature like that, it may not be the trazodone itself, and other, checking out other factors may be paramount here.
Dr. Tandon, a question came in. What medications affect sleep apnea?
Yeah, so muscle relaxants like baclofen, pain medications, so opioids specifically, can affect sleep apnea, can increase your risk of developing sleep apnea. There's a question about thyroid pills. If you're hypothyroid and you're not taking your thyroid pills, that can worsen sleep apnea as well. But our main focus is on muscle relaxants, as well as sleeping pills and pain medication, and in the form of opioids. Now, I'm not recommending that you just stop these medications, and specifically with pain medication, a lot of these are necessary, but they have been shown to increase the risk of developing sleep apnea.
And just to follow up the question that came in the chat room about being hypothyroid and taking the thyroid pill in the morning, it says, could taking my pill at night create better sleep? Dr. Boulos, do you want to comment on timing of medications and sleep?
Yeah, this has been actually a very interesting area of research that we've actually been exploring at Sunnybrook through different avenues. But basically, there is some evidence that potentially taking medications at night might be more beneficial. And I'll tell you, maybe not necessarily thyroid medication, but for example, blood pressure medication. I'll give you the reason why. Is that the highest risk of actually strokes and heart attacks is between 6 in the morning and around 11 a.m. And the reason for that, it's thought to be that there is actually a spike in your cortisol levels, or really your hormone levels, that sort of get you up and running in the morning to start the day. And so we, again, as a stroke neurologist, we see a ton of cases in the early, or at the beginning of the day, as people are getting up and running. If you think about it, then if I take my blood pressure medication at night, it will actually become most effective, because these pills, when you pop the pill, it doesn't become effective immediately. It becomes effective after a couple of hours. And in fact, its peak efficacy may be closer to that time between 8 and 11 or so, where you're between 6 and 11 a.m., where in fact your risk of stroke and so on is higher. Now, for thyroid, it might be less of a relationship like that, but there is some thinking, again, that taking your medications at night may have that benefit for a vascular benefit.
Just a follow-up question I'm going to direct to Dr. Lim. Can sleep apnea account for abnormal blood pressure readings when you awake in the morning, as compared to normal readings during the day?
Yeah, I'm going to say maybe yes, but I'm actually going to bump this one to Dr. Tandon, who's the expert in this area.
Yeah, no, it's actually that and blood sugars. So it's by the same mechanism that we discussed, is that every time you have a stoppage in breathing, you get a surge in cortisol that leads to the high blood pressure. And what's interesting is by the morning, you can, when you wake up for those first few hours, you're still riding that high of cortisol and blood pressures are still elevated. So, and it's the same kind of pathophysiology for diabetic and sugar control. And one of the more common referrals is that blood sugars are high in the morning, blood pressures are higher in the morning. Let's refer and see if there's an underlying sleep apnea. So absolutely a concern.
Dr. Tandon, we've had a few questions submitted regarding CPAP comfort and how to get a good mask fit, etc. How do I manage the discomfort of the device? What are your overall suggestions?
Yeah, so I think the first thing to remember is it takes time. Many of you who may have gotten diagnosed with sleep apnea, this is not something that you developed overnight. This is something that you've had for some time. So it's not a race to get onto CPAP. It's something that it's important to take time to get there. Some patients love it. Some patients start their CPAP and they swear by it and it changes their life immediately. For some people, it will take a little bit of extra time. And so work closely with the CPAP company, try on different masks. A lot of people think that if it's the smaller mask is better. I would argue that ignore the size of the mask and just see what's comfortable. If you're a mouth breather, you might be better with a nose and a mouth, a mask that goes over the nose and the mouth. And then sometimes if patients are having trouble, I tell them just wear it a few hours during the day. So wear it while you're reading a book, wear it while you're watching TV. And when you start kind of learning to breathe with it on and are more comfortable, then transition to wearing it overnight and take your time. And, often I'll tell some patients it can take up to a couple of months to get used to it and not to rush, because this is not something we want to rush. It's more, the end game is more important than how you got there. And that if we can transition you to wearing it 4 to 6 hours a night, then that's worked.
Okay. Dr. Boulos, do you have any experience with or views on the efficacy of stimulation devices, such as the AlphaStim device? Do you have any concerns about using it without medical supervision?
Yeah, so I'm personally not familiar with the AlphaStim device. With all of these, there are a large number of new medical devices coming out in the market, and some of these will get FDA clearance and some of them won't. But regardless of whether they do have clearance, this should always be done under the care of a physician, just to make sure that you're not harming yourself, or at least you're not wasting your money on something that's potentially not beneficial. But again, that's a very personalized thing. And again, a lot of these things have rave reviews or whatever. I'm not talking only about this one product that was mentioned, but other things as well. They come with a very strong marketing pitch, yet they are not really well studied in the literature. And so it's good to get your doctor or your specialist's opinion on them before proceeding with them.
And to follow up, Dr. Tandon, a number of devices have come out for alternative therapies for sleep apnea management, such as nerve stimulators. What's your current understanding of the role of these devices?
Yeah, I mean, there's a lot coming out. I mean, I think since CPAP was invented several years ago, I think there's been this quest to try and find something else to treat sleep apnea. CPAP has stuck around. I think that there has been work done specifically in nerve stimulation, hypoglossal nerve stimulation. There are trials. It's being done in the US, it's being done in Europe. It's slowly coming to Canada. And interestingly, we're just having a conversation about this, is that, I think it's done specifically by surgeons who were trained in sleep medicine, and most of these training programs are in the US, where they would have to go in the US and bring the training here to Canada. There are a few devices that are approved in Canada, not many of the ones that you might read about. Canada is a little more stringent with getting these approved from a medical device perspective. That being said, there are ENT physicians who are doing some of these stimulation implants, and there have been studies that have shown that they're positive.
Okay, and I'm just going to loop back to Dr. Boulos. You're doing a study on upper airway strengthening, not with devices, but with physiotherapy. Can you tell us a bit about that?
Yeah, thanks so much, Dr. Murray. Very happy to discuss that. And, Dr. Tandon had mentioned the didgeridoo, and Dr. Lim had alluded to also some research that we're doing. But in fact, there's some evidence that natural actually breathing exercises, or the medical term is oropharyngeal exercises, but basically exercises that strengthen your upper airway, may be beneficial to help treat sleep apnea. So in a trial that will start very shortly at Sunnybrook, being coordinated again by everyone you see on the Zoom on the Zoom call, we're actually testing and seeing if breathing exercises can improve sleep apnea and reduce its severity in people who can't tolerate CPAP. So if you're interested in a study like that, or interested in joining our research, we'd be actually extremely grateful for you to be referred to any of our clinics here. And again, all the sleep doctors at Sunnybrook are involved, and we're working all together. So again, thanks for the opportunity to mention that. But again, if you're having a hard time using your CPAP, you have sleep apnea, you've been diagnosed with sleep apnea, can't use your CPAP, this is potentially a really exciting opportunity for you. And we'd be thrilled to have you with us.
So thank you very much. And just to kind of loop back there, if you're interested in supporting our research in any way, or you find these topics of interest and interested in supporting them, please reach out to me. I'd be happy to talk with you. At this point, I'm going to conclude our Q&A session. I think we've addressed most of the questions out there. And I want to thank all the participants and panelists for their participation. Before we wrap up for the evening, I have a few more points to share with you. First of all, please be sure to take a moment to fill out the electronic evaluation form. It will help us plan future topics of interest for you. You can also add your name to our mailing list for future sessions if you've not already done so. I'd like to once again thank our speakers for an incredibly informative evening and the amazing work that they're doing, Dr. Lim, Dr. Boulos, and Dr. Tandon. Thank you to Mr. Colin Lynch from the Sunnybrook Board of Directors for welcoming us here, and a big thanks to all of you for joining in the discussion. Please be sure to check out our upcoming topics for the fall session, which will be shared on the Speaker Series website. Thank you again for being here, and have